Hi, I'm Dr. David Rubin from the University of Chicago Medicine. This is Best of the Day from the Advances in IBD meeting in Orlando, Florida. This is the 13th annual meeting and the first time that we're in Orlando, Florida. I'm here today with Dr. Athos Bousvaros, who's the Associate Director of the Inflammatory Bowel Disease Center at Boston Children's Hospital and also on the planning committee of this year's Advances meeting. This is the biggest meeting that they've ever had for the National Crohn's and Colitis Foundation of America meeting. Welcome, Athos.
Hi, thank you, David.
So congratulations, first of all. This looks like it's been a great meeting, and specifically in pediatrics, it seems like there's more people here than ever.
That's exactly right. I think a few years ago they opened up a pediatric track, and now I'd say we're getting close to 200 people in the room.
That's fabulous. And it certainly goes along with the growth of IBD in children in the United States and around the world, right?
That is correct. There's actually some pretty good epidemiologic data that suggests over the last 25 years the incidence of pediatric IBD is doubling, at least in those high-risk areas. And it seems to be rising most rapidly in the very young children, those under 10.
So that's a fascinating observation, and one in which there's been a little bit of science to help us out as well. So specifically understanding a little bit more about IBD subtypes, tell us more about these young kids that get IBD.
So, first as an overview, I think we can generally say that kids over 10 have genetically and environmentally the same kind of IBD that adults, young adults who get IBD do. Having said that, once you start getting between ages 5 and 10, it's a little bit of a gray zone, though most of those will probably have the typical adult type IBD. Once you start getting under 5, though, now you start seeing a significant subset of children, especially if they're under 2 or 3, who may have immune deficiencies.
So immune deficiencies, not overactive immune systems, or is that linked?
Immune deficiencies that may lead to overactive immune systems and inflammation.
So the yin and yang is out of whack.
Exactly. It's like patients, in adults, for example, patients with common variable immune deficiency can get autoimmune enteropathy. So when your immunostimulatory pathways are down, your immunoregulatory pathways may also be affected.
And have we been able to figure out the genetic components of these diseases or to treat them differently?
Well, we're starting. There have been identified some monogenic inflammatory bowel diseases in these very young children. Probably the best defined is the IL-10 receptor deficient patient. One gene affects this very critical downregulatory pathway, and as a result, patients get colitis, severe inflammation, and it's very unresponsive to anti-TNF. Another important group to think about is patients with chronic granulomatous disease. We have known for years that patients with CGD may develop colitis, and now there's some data coming out of the NIH that CGD, if given anti-TNF, you can actually harm the patient because while their colons heal, you can knock out the other arms of their immune system and set them up for pneumonias and other things. Now, however, there are these milder CGD variants that have been identified by Alex Muse up in Toronto that might be CGD, might not, and we don't know exactly how best to treat those yet.
So for the clinicians listening into this or watching this, what are the clues that make them think about CGD in an individual patient?
Well, I think, the first thing is, probably any child under 3 who presents with inflammatory bowel disease needs to be evaluated by an immunologist. There's now a new international consortium called NeoPICS that will help identify children with immune deficiencies and even perform whole exome sequencing as a research tool to discover new variants. But the phenotypic clues, no surprise, recurrent infections. So with CGD, it would be recurrent pneumonias, recurrent skin infections, osteomyelitis, or anything that might be infection with an unusual organism.
And lest some of our adult colleagues think that this doesn't apply, there are variants that can be diagnosed in late adolescence or even early adulthood, right?
Absolutely. Just like, celiac disease can present at age 2 or at age 75, there are milder versions of immune deficiencies that can present in adulthood. So it's something just to kind of think outside the box about.
Right. And perhaps some of the early onset IBD that you're describing will give us clues to understand variants that explain some of the other IBD we're seeing.
Well, I think you're right about that. I think you know this, we're going to have, at the end of the day, probably 50 to 100 different kinds of inflammatory bowel disease, each with a different genetic and or environmental etiology. And I think in 10 years we're going to have a new classification system. We won't be talking about Crohn's disease of the ileum. We'll be talking about Crohn's disease that's ATG16L1 positive and an infection by, Bacteroidetes or something.
Right, and I think when that can be tied to treatments or maybe even
Right.
cures, we're going to really get to where we need to be.
Exactly.
And that's a recurring theme in some of the other interviews I've done for Best of the Day.
Mm-hmm.
So you mentioned Neopics. There's a couple other major consortia that are working together. I think Pediatrics has really done a great job doing this. Can you tell us about those?
Certainly. So I'll mention 3 consortia and some of their lead investigators. Neopics is an international consortium that's headed by Scott Snapper at Boston Children's, Alex Muse at Toronto, and Christoph Klein in Germany. And again, it's really to study the genetic basis of these of these very early onset IBD patients. There's a similar European consortium called Genius that's doing the same thing. The large Crohn's risk consortium that's taking more typical cases of Crohn's, both young and old, and looking at outcomes is called RISK, and its purpose is to identify risk factors, and the heads have been Sue Berkugathasan and Ted Denson, Francisco Sylvester, and that's sponsored by CCFA.
Good.
And then the third group...
So risk of complications like surgery and
exactly.
growth and developmental delays.
Yeah, what they're doing is they basically are studying about 1,200 kids with Crohn's. They're enrolling them the day of diagnosis. They're getting data on genetics, microbiology, and serology. And then the big and the hard part is they're going to track these patients for a 5 to 10 year period and see who develops complications, strictures, fistulae, growth failure, and see if they can tie genetics, microbiology, and serology to complications.
Oh, that'll be really an important study.
And then the UC counterpart to that, that's also been sponsored by CCFA, but primarily funded by the National Institute of Health, is called PROTECT, which is by Dr. Jeffrey Hyams, is the lead investigator. And again, all these consortia have, between 30 and 50 sites, so we're part of all 3, and we're going from there.
Yeah, but I'm sure that parents and children and patients everywhere, and really our colleagues are really happy to see you guys collaborating in this regard, because this is the only way we're going to move forward.
No, it's been amazing, and I can tell you it's taken a lot of work. That the lead PIs to get 50 sites signed up is not easy.
No, I completely understand.
Not
I can
easy.
only imagine the conference calls that go on.
Yeah.
Well, that's great. So we mentioned briefly development and growth. At this meeting, there's some discussion about that. What have we learned in pediatric IBD?
So a lot of interesting things have come out about growth. I mean, we've known that growth failure complicates pediatric IBD, primarily Crohn's disease, for the last 30 years. What we haven't really known is what the best way to track it is and what the best medications for it are. And now I think it's clearly coming out that to treat growth failure in pediatric IBD, you need to do 3 things. Number 1, most importantly, is to control the inflammation, suppress the disease and reduce disease activity. The second is to minimize corticosteroid use, because corticosteroids suppress growth. And the third is to optimize nutrition. So, in summary, if you've got a child with bad growth failure, the 2 most important therapeutic modalities are optimal nutrition and biologics. Biologics seem to be more effective than immunomodulators and corticosteroids, certainly. in treating growth failure. And data presented by Tom Walters yesterday actually showed that infliximab very nicely improves growth if you follow patients over time. What he did was he did something that other people haven't done yet, which is he actually compared a child's growth with respect to their parents' growth. So, if mom is 5'4" and dad's 5'6", the child genetically probably won't be playing in the NBA unless there's some tall uncles in the family. So what he did was he corrected and looked at pediatric growth in terms of mean parental height. Right. And he was clearly able to show that infliximab seems to do the trick if you're on it long enough, as long as, of course, you don't lose response.
So that leads to a natural question which comes up all the time in all of our practices, but I'm sure especially in pediatrics, which has to do with risk of therapies. So what are we learning about exposing children to these different therapies and safety and other issues? Obviously, we balance it with the risk of the disease, like you've just talked about, but has there been some new information to guide us in that regard?
I think this is an area where we need additional work. I don't think there are any large prospective registries that are tracking drugs as well as we should. There is a company-sponsored registry out of a couple of companies now that are going to be looking at this. In the adults, they have the TREAT registry for infliximab, and there's a pediatric counterpart to that is undergoing. But I think the general impression by clinicians is that these medications, for the most part, and that includes, even steroids if used judiciously, immunomodulators and biologics are preferable to uncontrolled disease. One particular risk, rare but real, that we see in children with thiopurines is that of lymphoma. The precise instance is unknown. It is probably based on a study that we performed, probably about 1 per 2,000 patient years, so it's really quite rare. But there clearly have been lymphomas reported, including the hepatosplenic T-cell lymphoma, primarily seen with combination thiopurines and biologics. So our main concern is that's our best treatment. When you look at studies and efficacy and everything else, that's our best treatment, azathioprine and infliximab. However, if it causes lymphoma and significantly increases the risk, how long should you go with combination therapy? Yesterday, Bob Baldessano, in a talk on this particular topic, suggested that 3 years of thiopurines, your relative risk of getting lymphoma doesn't go up too much. But once you go past 3 years of thiopurine therapy, at least in adults, the risk can go up significantly. So the question that I think we're all going to be looking at is maybe we should be limiting use of thiopurines. I mean, we don't want to get rid of it at this point because they're highly effective treatments. You don't have to worry about antibodies developing to thiopurines, and they work with a lot of patients.
Well, and you debated the topic yesterday and made some very good points about that.
Yeah.
A similar theme in adult IBD has been this issue of de-escalation or withdrawal of therapies, which is related a bit to what you said about what Bob presented and others have talked about. So it leads to the next part, which is when you withdraw or de-escalate a therapy in any of our patients, we want to monitor them for recurrence. In pediatrics especially, we're not so excited about taking them back to the endoscopy unit. So how are you monitoring kids to know that their disease actually is under control, and when you withdraw therapy or adjust dosing that you're doing the right thing?
So I will be honest, in my clinical practice, I rarely de-escalate therapy because my goal, once I get a child in remission, is to keep them in remission, give them a healthy childhood. It's such an important time for not only physical growth, but emotional growth, that once I get the disease under control, I rarely de-escalate.
So how do you monitor to know you got it under control?
So we are now increasingly practicing like our adult counterparts. So if I start a patient on, let's say, a thiopurine, I will do examinations typically at the onset of disease, MRI, endoscopy, colonoscopy, labs, and then 6 to 12 months later, I'm going to repeat those examinations to make sure I have appropriate mucosal healing, I have radiographic healing on MRI, I'm not seeing strictures, and if I'm still seeing signs of disease activity, I'll escalate to a biologic at that point in time. And I think parents and children understand that now. What I always tell them is Crohn's is a sneaky disease, and you can look pretty good on the outside, yet still have disease brewing on the inside that might cause problems.
Yeah, I think that's a valuable message, especially in children, but I think in all of our patients, that there is a price to be paid for subclinical inflammation or even accepting active disease because they're worried about the next steps in therapy.
And again, I would say it's all relative. If I have someone with mild ileal Crohn's and they're, say, on an aminosalicylate, I may just live with that and then, follow up in a year or two to make sure things aren't getting worse. But sometimes we don't want to overtreat patients. Not everyone needs to be on, a biologic from day one.
Right.
Yeah.
There was an interesting session yesterday in which there was some discussion about enteral therapy and some of the nutritional interventions. Where are we with that in pediatrics?
So I think that enteral therapy is an accepted practice for induction, meaning, getting that patient with active Crohn's disease well initially. There's also evidence that it helps with growth if you use it. The real issue is, can it be used for maintenance treatment? And I think there's medical as well as psychological questions to that. The medical question is, okay, a child's basically had a nasogastric tube for 8 weeks, or they've been drinking nothing but Boost for 8 weeks. Now they feel a little bit better, but they also want to eat. How much can they eat before the disease flares up again, especially if they're not on other treatments?
Right.
And I don't think we have an answer to that yet. Dr. Baldessano presented some very preliminary data that says there are certain kinds of diets, vegetarian diets and diets low in red meat, perhaps the specific carbohydrate diet, though he didn't talk about that might help control disease in patients with kind of mild to moderate Crohn's. But we really don't have good data on that. We need more prospective studies. The other interesting area is how diet affects the microbiome. And it's very clear that going from, say, a westernized diet to a more vegetarian diet, more rural diet, paleo diet, clearly alters bacteria in your microbiome within a few weeks at least, maybe even faster. The question is, does that really reverse inflammation? Yeah. And there I think the jury's still out.
And I think that the key here is whichever intervention somebody is going to try or recommend, monitoring and making sure they're achieving their goal of controlling the disease, as you mentioned, is really important.
I think that's right. And again, if someone has mild Crohn's or mild colitis and they want to try dietary therapy, complementary therapy, and they're willing to kind of have us continue to follow, I'm okay with that. However, obviously, the sicker the patient is, the more you really need to use the medications that have been demonstrated to be effective.
A question that comes up a lot to all of us, really, is what is the risk to other family members? So we know that, for instance, siblings have the highest risk, unaffected siblings, for developing IBD. What do you tell families when they ask you about this?
So it's a very common question. The numbers I usually quote when a parent comes in and they have one child with IBD and they want to know, what's the likelihood my other child will develop it? Again, the studies are all over the map, but usually it's between a 3 and 8% risk if you have a single proband, meaning the child I'm seeing with IBD. So when when mom comes in and they bring, let's say I've diagnosed George with belly pain, with Crohn's disease about 5 years ago, and now Esther comes in and she has belly pain, and mom wants to know, is this Crohn's? What I tell her, it's a 3 to 8% chance that Esther will develop Crohn's over her lifetime. Looking at it conversely, a 92 to 97% chance she won't. So often with these patients, because the risk is higher, I am doing the investigations,
Sure.
especially if, say, the CRP is high or there's a little diarrhea. But more often than not, I don't find it, which is good.
Yeah, I think that is good. And the way you framed the discussion sounds like it's very reassuring to these parents.
I try.
Well, I want to thank you for this discussion today, and congratulate you on a really successful meeting.
Right.
This has been a great meeting, and I'm sure next year will be even better.
Yeah, thank you very much. There's a ton happening in pediatrics, and thanks for making it such a prominent part of the meeting.
Absolutely.
Right.
I'm David Rubin, and this is Best of the Day from the Advances in IBD meeting. Joining me has been Dr. Athos Bousvaros from Boston Children's Hospital. Thank you for joining us.